this problem. Subintimal PCI, stent under expansion, stent malposition, or HT section, we can see, unfortunately, many patients. Other problem with calcification impaired stent delivery. We can see the degree of the calcium score and under expansion rate. If you have high calcium score, your stent is probably undersized without IOS. How can we evaluate the coronary calcification? Is conventional angiography sufficient to detect or evaluate the coronary calcification? Answer is no, absolutely. As you can see in this image, IOS is more sensitive technique to detect coronary calcification compared to conventional angiography. In angiography, can not detect calcification in about half of patients. In IOS, we can detail evaluate the calcification. To determine the degree of the calcification, we need to evaluate calcium thickness, angle, length, superficial or deep calcification, calcified nodule, which it is related to acute coronary syndrome, or it is also give some information about the next procedure, rotablator or NC balloon technique. How can we describe the severe calcification? In angiographic definition is that radiopacity seen without the cardiac motion, usually affecting both sides of the arterial lumen. There is no clear definition, IOS definition for severe calcification. In IOS, we need to evaluate the different parameters for grading the calcium severity. That is angle, calcification thickness, or length is so important parameter. Calcified nodule is important point I mentioned before slide. You can see the calcified nodule. Calcified nodule are defined as convex shape of the calcium deposit on the luminal side of the arc vessel. This is fibrotic plaque, and it is not nodular calcification. Also, you can see acoustic shadowing. Angle is important, calcification angle. You can see circumflexial calcification. As discussed before slide, calcium should be described according to its location. If calcium location is close to intimal and is located at superficial 50% of the plaque, we define it as the superficial calcium. You can see superficial calcium. Calcification close to lumen. Also, you can see calcification gray color. And it is located the deepest 50% of the plaque, and it's close to adventitia. This image. This means deep calcification. You can see other animation. Dr. Raja mentioned actually this algorithm. We are different algorithm to manage the calcific lesion. In all algorithm, we use of the IOS is essential. If calcification arc, calcification length, also thickness is important parameter. If you have any of above parameter, or you have deep calcification, you need the adventist technique to perform optimal PCI. If you don't have the none of them, you can use a non-compliant balloon or scoring balloon, use your patient. Other algorithm, you again need the intravascular imaging to evaluate the calcium arc, length, and thickness. If you have 1 or 2 point non-compliant balloon may be sufficient, but otherwise you need the rotablator lithotripsy techniques. Other different algorithm. If you have vessel narrow than 3.5 and you have calcified nodule, atherectomy should be considered for optimal PCI. A calcified nodule, you can see 2 o'clock position, all circumflexial calcium. One case, I will show you one case example. Maybe internet problem, actually the video format.
Nihat hocam araya giriyorum, kusura bakmayın.
They're ready and they can present the case, and then towards the end we can come back to your slides at the end. Can we check and see if they're ready with the live case?
Rasha, can you hear me?
Yes, great.
All right, and you can see me, right?
Yes, we can see you. Great
Right,
to see you.
thank you. Thank you very much. First of all, I'd like to thank Boston Scientific for giving us this opportunity. Today, we like to do a rotablation case with you, and I'd like to introduce my team. I have Ahmet Şakir on my left and Hashim Tuner on my right, and I have Gizem as a nurse and Samet as a technician. So before we start, I'd like to ask Mohammed Hashim, who's from Pakistan, a fresh fellow of me. He will present the case for you. Go ahead,
okay.
Mohammed.
Thank you, sir. Today we have the calcified lesion. We have 62-year-old gentleman who presented to the emergency department, not in our hospital, but somewhere else in the other city of Turkey. He has 20 pack years of smoking. While on ECG, he was diagnosed as an inferior wall MI and shifted to the cath lab with informed written consent. So on angiography, there was a diffuse severe lesion on LAD involving both the diagonals. You can see a highly calcium coronary on LAD. While there was a severe diffuse lesion on circumflex starting from ostium, while as it was evident from ECG, there was total occlusion of RCA from mid-segment. So he was dealt accordingly. Primary PCI of RCA was done and TIMI3 flow was achieved. In index hospitalization, he was a stage PCI to circumflex has been done. And meanwhile, as there was the circumflex gets total, but he again rewired and some flow was achieved. Then on the same setting, FFR to LAD was done. As it was looking in some views, it was moderate lesion. So FFR was done, which showed significant. So it was 7.5. So then again, he contacted Dr. Umar Kartigan for further treatment. So here we have this patient on our table in Memorial Hospital Cath Lab. So this is the plan for today's session, and I hand it over to Professor Dr. Umar Kartigan. Yes, sir.
Yeah,
Thank you.
right. So let's show you today's angio we have done. Can you come the first image for us, please? Yes. So you saw that the RCA and circ lesion already treated, and this is circ, looks very nice. Although the final image of the small circ is not good. After 2 weeks, we have nice circ filling. Do you see that?
Yeah, it's definitely
it's better.
Than what you left with.
Yeah, it's better now. Okay, so I think the expansion of this stent looks quite okay for us, at least by angio. This is spider view. Can you come back spider view, please? In here, What do you think for the ostium of the LAD? It looks definitely calcified, but also there is moderate stenosis at the ostium of the LAD. Do you agree with me in that position?
Yeah, I agree. We'll go around too before you jump into the case. Just going through the panelists here, Şevket, would you just try and see balloons first and see what happens?
Let me show you. Yeah, sorry. Let me show the fresh angio, and then you.
Yeah,
I like you to discuss this case, and also maybe I can show you the IOS first. Oh, this is long lesion. You know, according to angio, I think there could be a breach at the end of the lesion. We have first and second diagonal. First diagonal is, you know, sizable, but the second one is good diagonal. We have to take care of that one for sure. Next, please. And it looks very heavily calcified. The lesion is eccentric, I would say. Next, please.
This is the last one.
Okay. Then we did IOS before connect you to show you IOS. And let's see the IOS first. And then you can discuss. Make the IOS image the
Bigger one.
bigger, please.
Did you have trouble advancing the
No,
IVUS cath?
no, it was straight. No. Straightforward.
Yes, Blake.
Okay, yes, play please. This is
the Opticross? Is this the Opticross IVUS?
Yeah, this is the Boston HD IVUS, Şevket.
Rota, bro.
And this is the distal healthy part. In here, the vessel around 3.1. And now we are coming to disease part. Not that much calcification here to my view. There is a breach here. Do you see that the breach? There is a breach from 8 to 11. There is a breach here. I think looks like it's not maybe it's not maybe the best example of breach, but I think there's a breach there. And we are coming to proximal.
See, it looks like there are tandem lesions there. There's one earlier that we just saw, and this is the second of two.
Right, yes. And we are, the diagonal is coming, and this is
Cranial. Cranial. Önceki.
and here we have heavy calcification. Here is almost 360, and so we have very calcified lesion. Then we can't see much beyond the calcification.
Right, so great shadow example of
true.
calcification on IVUS. And I'm assuming you went all the way to the left main, which we're probably about to see in a second, just to see how significant that the osteal lesion is.
Okay, now the circ will come, and please note the ostium of the LAD. If we cover it or not, that's I think the important decision we have to make if we stand LAD from the left main or not. This is the circ, and it's just they practice stand that just the ostium. Left main is around 5.5. Yes, this is the IOS before ablation.
Excellent demonstration.
Yeah.
We'll go around just quickly to see how much would be comfortable stenting right at the ostium, or would you extend it to the left main? Şevket?
Before you ask my opinion, I wanted to see the IVUS. So IVUS is very mandatory in deciding how to proceed in calcified lesions. So now we have the IVUS, so we know the vessel diameter, so we have a 360-degree arch calcification there. We definitely should go with the rota there. At the proximal part, I would like to measure the minimal lumen area at the osteo part of the LAD, and then I would decide whether I go through into the left main or not. But this is definitely going to be a rota case for me, according to IVUS.
Professor Nihat, how would you approach this?
I suggest the rotabulator because there is a circumflex calcification and calcific nodule. I see area calcific nodule. Also long segment calcification. There is a good rota indication. Also circumflex osteum was good in IVUS. Two options is reasonable. Maybe Ballon-Gale technique for use, circumflex osteal, for prevent the plaque shift. But crossover the left main is more reasonable technique.
Again, measuring the osteal LAD MLA, if it's less than 4, definitely then we should cross over into the left main. One thing I just want to mention, that diag, which is the big one, the osteo of the diag looks slightly retroflex. So hopefully the wiring of that one won't be an issue. We really need a two-stent strategy. You can avoid coming into the left main and making it a double bifurcation case. That would be great. So definitely agree with Şevket. Look at the osteo of the LAD and see what the MLA is. If the MLA is more than 4, I won't come into the left main.
All right, and I can see with this eccentric calcification, atherectomy is definitely a great approach here, as opposed to other modality, NC balloons and IVL.
Okay.
You can go ahead and let us know what where you're at now.
Okay, yes, so we just here, we did IVUS and nothing more. We inserted our rota wire with help of Mamba Flex, which is microcatheter we use in CTO. And I use here extra support rota wire. The reason is we have eccentric plaque here, so I thought that is much helpful than floppy rota wire. What do you think in that point?
Definitely, yeah.
Okay.
Idea.
Yeah, okay. And
do you typically use it routinely in most of your cases, or are you selectively in the ones with very eccentric?
Right. So today we are using Rota Pro. We have Rota Pro, and it's almost ready. I'll show you how we prepare it. We of course connect it with the liquid, and we have to open and make sure if the liquid is coming. This is important to see, and liquid is coming.
Yeah. Professor Omar, before you move on, just quickly, Dr. Asad mentioned a good thing that we usually use the Rotaglide. That's already a done solution for you in the US, but in the Middle East, you do your own. Do you do your own solution?
What as you mean the as operator?
Rotaglide.
No, I mean
no, we don't use the no, we don't specific fluid for that. No.
But since I have heard it from Esad, I am doing it now in all my procedures, and I don't know how helpful that is. But since then, I haven't encountered any stack of the wire in the rota. So I think it might be some kind of helpful. And propofol just 2 to 3 cc in the back, and we should also be sure that the fluid is dripping very fast, because if you don't have the fluid dripping very fast, the wire gets stuck on the rotabur. So we should check that, and I have learned that from Esad. Thank you for that, Esad. Propofol would be a good solution.
All right, I didn't use it. Anyway, we have in our bag, we have 5,000 heparin, 5 milligram of verapamil, and 5,000, how much? 5,000? 5,000 nitroglycerin. All right. So now I am inserting rotawire into wire port with carefully.
And what size burr you're using?
Ah, yes, that's important because, sorry, I'm using here, what do you suggest, first of all?
What is the vessel size on the IVUS? What's the distal vessel size?
Yeah, the distal is trio. When you go to the proximal 3.540.
175.
175, okay.
175 because probably your calcium is mainly proximally.
Yeah.
So maybe a 175.
Right, I choose the same 175. Yeah, because if we can start with the smaller one, but the cost will be doubled. So we choose 175
directly
for the one. So when we insert the wire, the rotablator catheter should be straight, and we should aware that not to bend of rotawire, you know, by advancing the bird. This is very important. So now, did you have the wire there?
No. Not yet.
And Ömer, can you give us some insight about your setup? Is it a radial procedure? Are you doing it radial, 7 French, 6 French, 8 French? How is your setup?
Basore.
7 French.
Yeah, sorry. We are working over 7 French EBU by radial approach. Okay, a little bit more.
Yes.
Okay, here, stay
Yes.
here. We will do some control. And now I insert my burr. So, where is wire clip? This is wire clip is very important tool. Before testing, we should, you know, wire clip should be set at the end of the wire. Otherwise, when we do test, the wire will be king.
If you can have the camera right at the bottom. Yeah, great.
Yeah.
Causing a knot with the swelling of the wire is a nasty thing,
yeah,
so everyone want to avoid that.
You can leave this wire clip over the table, or you can set it at the docking port, which we will do.
Yes.
All right.
Keep it
So
straight.
now, yeah, we have to straight. So do you see that? And
Yeah.
yeah.
You're going to do a test
then
run.
we push the advanced knob to start rotating burr, and we will see it.
Yes.
And we will test it. I like to have 185,000. It could be 180 to 190 RPM. Let's do it now. Can you show the camera?
Device.
We would like to see the proximal part of the board. Can we see the proximal part of the board, please?
Yeah.
Yes, exactly.
Yeah. Okay. Make it 185. Elif. All right.
We would like to see how the fluid is dripping.
We have to make sure, you know, burr is smoothly rotating when back and forth. Okay, stop please. Yes. Okay.
Yes.
And we always want to make sure that the burr is not touching anything.
Yes.
to-
Anything.
Yeah.
Right.
Yeah.
So we have to be aware not to wind anything in rota burr. Yeah, very important during the test. Right. So we can insert it now. When we do insert, so before we insert, we have to insert advanced knob, you know, like to the you know, ahead of the rail and by 2 fingers to get the room for pulling it back. So it's like that, 2 fingers width. We are ready to go.
Yes, keep it straight.
When we go inside, you are ready?
Yes,
Okay.
I am ready.
We like to have dyna mode. Okay, we activate the dynaglide. You see the screen we have in the dynaglide. Show them.
Any comment about the Dynaglide?
Yes.
I don't use a Dynaglide for going in.
Yeah,
what about you, Esad?
All right. Yeah,
I always do. I always press the first pedal on Dynaglide before even starting burning. So I always go up and come out both on Dynaglide. But I don't go on an activated Dynaglide going in.
All right.
That's what you mean.
All right. It's a bit depends. Also, we keep the brake.
Makes it easier, probably. Yeah.
True. Yeah. Also, we keep the brake unlocked while advancing the burr. That's important issue.
Yes.
All right. So we are in the Dynaglide and insert. Yeah. Go ahead. Now wire is coming back at the end. You see.
Proximal.
Yeah. Go ahead.
Proximal.
Göstersene. Go. İlerle.
Probably watch the tip of the wire.
Left main'e biraz daha gidelim. Tamam. Biraz daha git. Biraz daha gidebilirsin. Gidebilirsin. Git. Left main'e gir. Tamam. Okay. Stay. Yeah. Okay.
Stop.
So now we are in the left, almost left main. I didn't go. I could go a little bit further, but let's start from here. So we are ready. Before start, I'll come back at the end of the rail, like this. Do you see my hand? Yeah. Okay. Now we are ready. So we have to advance the burr up to the platform enough a part of the lesion. We have to make sure we didn't, stuck the lesion. We didn't, occlude the artery. This is important.
Yes.
Now, right. Are we ready?
Yes.
All right. Okay, let's start. Dynaglide off. So we have to push gently. Now I don't have any resistance so far. Each run should be around, I have some resistance here. If I have light resistance, I can push forward. Okay, stop.
Now you are through.
About wire. Keep wire.
So I'll come a little bit back. We have to do it,
push
yeah.
my wire?
Yeah.
Slowly.
A little push gently, yeah.
No, I cannot.
Okay.
Because it is.
Yeah.
Drop the lock.
Hold the wire.
That's one of the reasons why I always use a microcatheter to deeply insert the rota wire. So the rota wire should be as deep as possible.
Yeah, I will insert it a little bit more with Dyna help, okay?
That's a good trick.
Yeah. So anyway, let's push a little bit forward and I'll do a little bit more. Yeah. I will start from here
Again, yes.
again. Each time, each run, it has to be 15 seconds. So our pressure is okay. We can give some fluid here. Okay.
This is nice.
Definitely a change from the first one.
Okay. Another run and okay. Okay. That's important thing that we have to park our burr at the end of the rail. Okay, not the middle or the other eyes. You have to come back at the end of the rail. I think we did our rotablation. Let's do another position. And then we finished it. Yeah.
Are you going to do another IVUS?
I will do IVUS again. Yeah.
Okay.
But after dilatation. with the balloon.
So it would be very interesting to see what the Rota did to the eccentric classification there.
Okay.
It would be very educational.
Right, thank you. So let's go with the again with the dial mode. We will remove it by pushing the wire. I'd like to show you how we do it. Okay.
The Y connector should also be opened. That's another thing.
Yeah, press it, please.
Copy. Yes.
The dyno should be pressed till the ball comes out.
Yeah, it's dyno glide mode. Yeah.
If you do it early, then the ball gets stuck again in the wire. So you have to pull everything
Did you have
out.
it?
Yes.
Okay.
Yes, exactly. Stop.
Okay. So.
Yes.
Okay. It's okay.
Yes, okay.
You can remove it.
Everything I am mentioning has happened to me. So that's experience. I can also give you some insights about my stacks. I had a lot of stacks.
So we have now, let's do one injection if we have anything wrong. Everything looks okay, but let's check it again.
Yes.
All right.
Yes.
All right. Okay. We did a kind of yeah. Did you? Now I'm sending microcatheter. No need. This is this is
yes.
long.
What do you think about cutting the rotor wire and then working about over the rotor wire?
Wire. We know everything about, how can we use them. So we don't know. If we use it, we will use it several times in a month. The best. So why I use this?
I agree. I just wanted to know whether anyone do it. Would anyone do it?
Okay.
Assad, you use 2 wires at the same time.
2 or 15.
We would, so
Boston
the rotor wire which stays there acts as helps you make your NC balloon as a scoring balloon. It also
Aren't
keep
you
your
worried?
vessels ready.
You do it while you ablate, while you're doing it.
This
natural?
time, this time,
Okay, okay.
this time,
All
But
right.
it's a newer
Yes,
technique.
okay. You can.
I can try it. I like
I
complications.
wouldn't have
Solving them is fun.
Right. So over the inside the Mamba, we insert workhorse wire, which is choice, and we will do dilatation. Before we do trio dilatation.
Scobie.
Yeah. Trio. Before we do trio dilatation. But before dilatation, I like to insert a wire to a big diagonal, because after dilatation I might have a dissection, and it will be not easy to go this big diagonal. What do you think? I think it's time to rewire it if you wire it.
I would protect it, yeah.
Yeah.
It will be very exciting to see you how to wire that diagonal.
Okay.
Are you using an NC balloon?
Sorry,
No, this is we are removing Mamba catheter, and I like to have another choice, please, for side branch, and we will keep it open for the first diagonal too. We like to we like to tell. Okay, how much
It's
the
not that bad.
how much the
Asa.
ACT?
We will do it
We
very
did two.
quickly. It's not that bad in this position.
How much is it, and then how much?
It
we can-
was 300.
All right. So our bunu kullandık mı canım?
Huh?
So we give
So in terms of the side wire, the
Normal
side
tabii.
wire
Tamam.
branches, like, do you always take the workhorse wires, or do you sometimes use those coated wires? Because obviously people are divided on it. Some people think that you might leave the coating behind the stem. If you leave it jailed, the other people might find it doesn't break that easily, so they prefer wiring the side branch with a floppy wire, a more hydrophilic wire. Do you have any preference, or do you always use your workhorse wire like a BMW or
if you ask me, Asad, I don't use hydrophilic wire unless I need it. You know, if I needed the SI node, I use, but I don't need. I don't use it if I don't have to use it, because hydrophilic wire is you know, very very slippery. We have easily remove back, and we have risk of easily going intraplaque, and we have risk of dissection, I mean rupture even with the knuckle. So if I need it, yes, I'm using it. So Şevket, this was so easy. Yeah. So I don't know why you are wondering.
No fun at all.
You know, this was the easy already.
Tricky, but
so let's do another one.
Another wire?
Or let's do another one.
When I see you struggling, not this one.
Right. Let's write the first diagonal, right? As well. Now, you think?
Yeah.
Tell.
Başka tel yok mu? Tamam, leave alalım.
Elif, give him a samurai. Don't let them work on choice.
No, it's okay. Choice is good. I'm not that rich, Şevket.
But Elif is rich.
So what do you guys do in terms of if it's
Göstersene.
an RCA, do you still use pacemaker, or do you do aminophylline? RCA, would you go with pacemaker or aminophylline nowadays?
The question goes to who?
If you're doing a rotational atherectomy in an RCA.
Goes to you.
When you don't know the answer, you asking who asking who? He's asking you.
She's asking everyone.
He's asking you.
While you're getting this,
she's asking me. So I do both. If I see a long lesion where I see there is going to be a very high likelihood of flow and stuff, I will probably preferably put in a temporary pacemaker. If it's a short lesion, I can get away with short runs. I will try to avoid pacemaker. So I'm not 50-50. I haven't totally moved away from a temporary pacemaker yet.
Yes, please.
Yeah, by me it's up to my mood. If I want to go on very aggressively, and if I want to work in a more aggressive manner, then I definitely go with the pacemaker. If this is a big RCA, and if I'm going there with 2-0 burr and want a debulking rather than modification, like a more debulking, then I would go with the pacemaker. But usually when I go with the 1.5 burr, then if you work in patients and if you work very slowly, you don't need any kind of pacemaker. Of course, you should always be looking at the pressure and at the rhythm. That's the key.
Essentially both, like you haven't really moved away from pacemaker completely.
Yeah.
So walk us through what you have there. What balloon do you have in there?
3.0 15 quantum maverick, right?
Yes.
Wow. You are rich.
Sorry?
You are rich.
I have to use NC, and let's touch here too, yeah. We have to be careful.
This is an excellent balloon. This is an excellent non-compliant balloon.
I think we have to cover all the way right up to here. Down.
Why don't you have the thinking of using some kind of scoring or cutting balloon? I'm just curious about.
I use already Rota, which is okay for me. If I couldn't open it, then I'll try maybe cutting balloon. Yes, we may need it to be honest. Yeah, I agree with you. But now let's try with the ANSI.
So it's open nicely. This is one of the lesions.
It's open nicely, but before inserting the stand, I like to go at the proximal part. I like to go with the 3.5 down, up and down.
But also,
16, 20.
If you look at the proximal
20,
part of the LED
down,
where most of the calcium is, he actually has 3 wires. So even an NC will work like a scoring balloon here.
3.5, 15.
2 other wires around it. So it might work as a scoring
20.
Yeah, poor man's scoring balloon.
Always.
Yeah, sort of. Poor man's scoring. And he already said he's not great.
Wow.
Yeah.
Ruptured. What type? What is it? So 3 or ruptured at 20, right?
Yes.
Okay.
Yeah, this is a good sign.
No problem.
That's okay.
This
no
is
problem.
a good sign that you need more plug modification.
Yeah.
So that was the reason why I wanted to see the iris after rota. Maybe we would have go directly with the scoring balloon before the NC. This talk is just for educational purposes, you know. So I'm not suggesting anything, but it would be, we have the iris on table. Why not going in there with the iris and see it after the rotablation? But now it's too late. We can do it anyway.
Did you ask any question, Şevket? I couldn't.
No, I'm just blabbing around.
Okay. Which mood are you today?
Keep working. Keep working. I'm in a good mood.
Okay.
I'm always in a good mood. When I see you working, I'm always happy. seeing such a giant interventional cardiologist.
Oh, come on.
Working and learning from him. It's always good.
Yes.
Okay, go up. This is 3.5. Yeah, go up. Yeah, okay. Yeah.
You see the balloon is going around the calcium. So I think that's a sign of deep calcium. So that might be the reason why I wanted to use here a scoring or cutting balloon.
Yes, go on.
Oh, I might use cutting balloon here.
Yeah, cutting balloon probably.
If it's now open.
No, good opening. No.
What do you think? It's okay. Not sure. Not sure.
This part good, but the proximal part needs some kind
not
of
sure.
modification.
Try it again.
Yeah,
Yeah.
Most of the calcium was on iris.
Yeah.
Okay. Yeah.
But we skipped that part already.
No. I think I'll do cutting here.
Yeah, cutting would be better.
20. Cutting.
Thank God you are getting richer and richer.
Cutting.
Yeah,
Proximal opening is
First
good.
NC counting, now cutting balloon.
Or scoring. Cutting or scoring.
I think
This is a Boston session, so we are going to do a Wolverine, I think. They don't have the scoring balloons.
yeah, I think
Okay. Yeah.
sort of
No.
scoring
Cutting.
Altı çok.
Okay. 6 is okay.
Yes.
Yeah,
maybe.
6 is okay.
Yeah, 3.5, but 6.
By
We
6,
have
yeah.
flextome cutting.
No Wolverine?
Not today, I think. Mostly we use, but this is
So
also quite good for me.
My camera is committed suicide, so I'm not on the screen anymore.
But I think, guys, it's important to see that part is not that opened well, right? This is important.
Right, there's a bit of a waste. It's
Yeah. That's why I like to touch by 3.5, Rasha. If I would go directly stand after 3, I wouldn't see that.
Expansion.
right. You're right.
But it's
And also in terms of sizing your cutting balloon, like you knew the vessel size was around 4, so probably 0.5 smaller will prevent any major dissection. So probably great sizing.
let's
Maybe just a wire, LED one.
here. Okay, go up here.
We have to do something for the diagonals.
Yeah, that's okay.
More?
14. 10.
This is also
10.
interesting to
Go
see.
up to 10.
We have a wire there, and we are
10, yeah?
cutting
You can go
also
12.
the wire somehow.
Do you think so? It's possible?
Yes.
I don't know. We will see.
Yes, now it's okay. Huh?
Interesting is with IVL, we can
It looks
do
okay. Down.
wide, and it wouldn't
Ay,
affect this. I wonder if it's
Hemşiresi başında.
Maybe from diagonal.
12, 14. Yeah, we need to have pain, huh?
Yes.
The IVL option is always off.
Yeah.
Off
I
the
think
table.
40.
Okay, let's see. I think it's okay now.
I think more proximal you should do it also. You see the proximal part?
Yes,
it needs also modification.
But you see, I'm losing diagonal. Maybe we have hematoma there.
Yes.
I think more than plaque shift, we might have hematoma. After dissection, we have to take care of the diagonal, and I think we will stand that.
And so.
And my stack technique will be crush rather than.
Yes. We need to do something.
Yeah.
Diagonal first.
I am craving for seeing the IVUS now.
Normal problem.
2.5 NC for
3.75
the
var.
diagnostic. What are you going to do?
3.75 NC.
You can do a nano crush for that diagonal,
3.75 NC.
just with a balloon in the lady.
Man also likes nano crush.
So guys, I like to touch with the 3.75 with that lesion once more, and I go diagonal. What do you think?
Diagonal first, yeah. You should definitely balloon the diagonal first.
Yeah, balloon it first because there's no flow there. It's probably
All right, let's okay.
let's.
Give me 2.5 balloon.
Balloon.
NC, yeah.
2.5 balon.
Yeah. 2.5, yeah.
Yes, yes.
2.5 balloon, yeah.
Once you deal with the
2.5,
diagonal,
15.
No. This.
once you deal with that diagonal, see if you have time to show us an IVUS run. If you put all of this to the council.
Normal.
Hadi o çabuk.
Çabuk var.
I mean,
You need the guideliner or an anchoring balloon.
anchoring balloon much be better. Okay, 3.5 short balloon.
Short balon.
So you have a standard segment in your search. Maybe put your balloon there.
12.
3.5 mu?
3.5 12. Okay, let's do anchoring because I have lots of wire. You know, I have to remove. Aç. But it's real life, yeah. I need this anyway for crush.
Yeah. Fair enough.
Omar is always a fan of anchoring balloon, and I'm a fan of Godzilla or guideline or something like that. I am the expensive guy. He is the poor guy. So
Slowly.
Yeah, they're extremely useful in cases like this where you have
Yeah, but yeah.
Yeah.
All right. So let's remove bir tane daha alayım balloon. I like to remove my course. So right. I think guys I use guideliner here. Godzilla. Do you have Godzilla?
of course, Boston is there.
Remove the stent and we will. Or we can.
Omar, would you consider that part again, ballooning with the cutting balloon at that part? We didn't have a cutting balloon at that part, you know?
Alone here.
The part where you are now trying to go with your stent,
Touch more.
this part has not been ballooned with the cutting balloon.
But I think there's a significant dissection too in that proximal.
Yeah, of course, there is dissection, but the calcification is also coming in the way, so you cannot push it. We need a smooth way, a smooth.
You know, there is lots of calcification and we break the calcification. That's why it's not easy to insert stents. That's the reason.
Yeah, but my suggestion is to go with the modification further, because if you even go with the anchoring balloon there, you have the risk of losing the stent inside the lesion. So my suggestion is going with the modification further.
We definitely go with Godzilla.
You're having trouble pulling back on the stent?
And there will be also an issue with three wires with the Godzilla. And the Godzilla will also be very tricky to go through the calcification. It might increase the dissection and even cause perforation. So I would definitely go first with more modification before going with the Godzilla or guideliner there.
Bozuldu. Tamam mı?
Bozuldu mu? Evet.
Bozuldu bu.
Hocam stent soyuldu. 7 alalım mı Kayseri'yi?
6.
6 Kayseri'den.
6. This is LED, yeah?
This is diagonal.
This is diagonal LED.
Yes.
Are you going to pull the wires out or just the 3 wires in the Godzilla?
Guys, what I do,
I think you should remove your CX and diagonal wire. And then
I will remove CX.
again that part before sending the stand. It's safer. Because
So we go
if you
with the,
cannot go with the guideliner in, you may need again some kind
we will do
of
clot, okay?
modification with the ballooning. You should do it beforehand, before introducing the guideliner at that lesion, at that calcified,
Stent as well.
dissected lesion.
Başka stent.
Because if you even go giving contrast from the guideliner, the pressure of the contrast is high with the guideliner, so you might increase the. You see what I mean?
2,5 kısa balon alayım.
Balon.
I would advance it with the balloon ahead. I think it's better to.
Masadaki
Ya.
3,5.
Evet.
Yeah,
15
we
mu?
do.
Daha kısa yok mu? It's long one.
The guideliner will only shorten the calcified length of the artery now.
AST sayıyor mu?
It's coming back.
Tamam.
Okay, 12, 14, 16. Down. It's really complex case, huh?
Yeah.
10,
Way
12.
harder than what it
14.
looks.
14.
Angiographically speaking, I would definitely go, even if I didn't have any kind of, I would definitely go with the
Stent.
Rota in this
Stent.
case.
Stent.
Hazır.
You have the typical cramp track
Leave, huh?
Hadi baba.
Yeah.
approximately. Yeah. Oh, great. So we got the guideline.
Hocam. Tamam. 2 tane ekleyeceğiz.
Tamam.
Tamam biliyorum. Çok zaman geçti.
Yok tekrar şey alalım. Çok karin yaptık.
LCT, yeah.
Toplamda 15 gün oldu.
Bu nedir?
Stent.
Sen 2,5-30.
3,5 yansi hazırlayın bana, niye olsun.
Sensin hazır.
Now I'll do clot, guys, here. Clot, okay?
What size stent are you using now?
3.530.
2.5.
2.5.
Yes.
Yeah, 2.5, sorry, yeah.
Yes, remove.
All right, let's see. Small injection, not
Yes,
much.
Yes.
We have dissection there. Very gently. Very gently. All right, this is nice.
Evet.
2, 4, 6, 10, 12.
Stent.
2, 4, 12.
Because
Mini clot.
I'll do mini clot, yeah.
Yes, yes.
Yeah.
So go up more.
Okay.
Go 18.
18, yes.
18.
Yes, good opening.
Okay. Show me there. I don't like the proximal part. Göstersene bu. Sine
Önce.
miydi bu? Sineyi göster. Öncekine gel.
Önceki gün.
Balona gel.
En son.
The proximal,
Yeah.
what do you think?
It's not opening.
Okay.
Go up.
3.5.
Yeah.
Do you want to take an
3,5
NC first?
NC?
Yeah, 3.5 for pot, yeah? No, 3.75.
3.75. NC. Tamam. Fark.
It's very frustrating when somebody is talking around and if you are walking, but Ömer is very used to it, so I think he will not be
3.75.
angry with us
Masadaki.
Ver.
İyi mi?
İyi durumda ama sen
if I am not teasing him.
What did you say? I didn't hear you. What did you say?
You are doing a very good job. That's what I am saying.
You know, I have lots of problems because you said lots of good things to me. That's why I had these issues.
Yeah.
Yeah. Test,
Yayını kapatabilir miyim? Bir saniye.
test please.
All right.
It's good here.
I do, yeah, okay, go up 10, 14. 14. 14. 20.
But good opening.
That's okay, opening is okay. Down.
Yeah.
All right, so what we do, what I want to do, I'll remove this diagonal and I'll like to recross it with this wire. So I hope I can do it, inshallah, and then I'll have a nice way to go down. Torque please. Torque. Ne yaptın ki? Burası açık, baktın mı?
Baktın mı?
eliniz
Peki, tamam.
üstünde zaten kapalı.
Tamam, this side better.
Kanır sıfırlar.
Alright. Bir 2-0 balon alabilir miyim? I like to use a balloon here for sport. I think this wire is kinked and needs balloon.